Thanks, Paul. I moved to Seattle a little over 3 years ago, and one of the pleasures we have of living here is to make short trips to Vancouver, and I've gotten to know the city very well, and it's a beautiful day to be here. So thanks, Paul, for having me here. What I was asked to talk about was PD outcomes around the world. I think it's important to get a context in which we practice. At this time, it's estimated, if you look around the world, there are about 2 million people that are undergoing dialysis. About 40–50% of them are between China, the United States. If you add Japan to it, that'll be about half the dialysis population in the world lives in one of those three countries, in the United States, in Canada, in the United States, in China, and in Japan. In at least two of those large countries with the larger populations of dialysis patients, there has been a tremendous growth in the use of PD. In China, it's estimated there are about 60,000 patients on PD now, of a total of about 250,000 patients. In the United States, which had been relatively flat in terms of absolute number of patients from the mid-1990s to about 2008. Starting about 2009, as you can see, there's been an upswing in the absolute number of patients undergoing PD, and it's my estimate as of today that about 50,000 patients on PD in the United States. I'm speaking to this group in British Columbia, which is one of the highest proportional use of PD. So one way of looking at it is that we, the south of the border, are catching up to the level of use that you've had in British Columbia and in many areas of Canada for a long time. And the third part of the world where it's important to recognize is the developing countries. Dialysis, as we know, is a very expensive therapy. And I think it's fair to say that most people with end-stage renal disease in the world don't have access to dialysis. So most people around the world that have ESRD will die for want of dialysis. So I think it's reasonable to think then when developing countries that don't have a lot of money to invest in healthcare, that they mandate that we will mandate the use of a therapy that will allow us to treat more people and have more people live rather than die with a modality, for example, PD. It started off in Hong Kong, and the other part of the world that has done that is Thailand. And I have a pointer here, and I can point right here to orient you. This is a very complex slide. This right here is the number of units that provided peritoneal dialysis in 2007 in Thailand. And as you can see, this is about the time when the policy was implemented. That number was only about maybe 15 or 20 units that has gone up to about 100 units around the country of Thailand. This is the number of private hemodialysis units that has remained constant over that time. This is the number of patients that is receiving peritoneal dialysis in Thailand. Pardon me, let me just go back. I think it's telling me I'm spending too much time on this slide, but this is the number of patients in PD. There's been a rapid increase in the use of peritoneal dialysis in Thailand, so that now about 50% of the population is being treated with PD, 50% with hemodialysis. It's a very complex healthcare system, like most healthcare systems are, and that explains why it's still 50-50, even though the governmental policy is PD first. Be as it may, those are the three areas in the world, in China, the United States, and in Thailand, that there's been a very rapid growth in the use of PD of the likes that I think the PD world has not seen. And you may have heard that there was a shortage of solutions in the United States that persists to the day. For people on cycler, there's a delay for us to get people on cycler because Baxter cannot make bags fast enough to catch up with the demand that has been escalating quite rapidly. So which outcomes are important? It's something that it's my thinking has evolved over the years as I've spent more time in being a physician. I want to take this as an example. SONG stands for Standardized Outcomes in Nephrology. It's a group that is based out of Sydney, Australia. They've undertaken a 5-phase multi-method project to identify outcomes that are meaningful to patients and caregivers. And they've started for hemodialysis. They've almost completed that. Their papers are in publication. Song Transplant and Song PD are being planned as well, but I'm just going to use Song HD as an example. And the data have primarily been collected from Australia and Canada, in Canada primarily from Alberta, and it's mostly Caucasians, and 30 to 40% of patients are undergoing home hemodialysis. So one has to be careful in not extrapolating it too much, but I do think it conveys a message in what is of value to patients and caregivers. So this is, they asked also health professionals, and I want to focus in what the health professional identified in order of importance as the 10 most important outcomes for people on hemodialysis. And as you can see, a lot of these are what we deal with: vascular access problems, death, mortality, cardiovascular disease, drop in blood pressure, hospitalizations, fatigue, infections, dialysis adequacy, and blood pressure. What was quite I should not say surprising, but I think revealing, is how the priorities of the patients and caregivers are completely different. As you can see, they put dialysis adequacy not in terms of small solute clearances, but dialysis adequacy as in their sense of well-being from dialysis treatment. Ability to travel, vascular access problem, fatigue, dialysis-free time. How can I get more time off dialysis? Which is to Tom's point on how many hours would you increase on the cycler to achieve adequacy guidelines? That is dialysis-free time. Washed out after dialysis, cardiovascular disease, anemia, ability to walk, and blood pressure. What is absent in these top 10 is death and mortality, which has almost exclusively been the focus of the scientific research community. Has been focusing on, and I think this is one of the focuses that has hampered the growth of peritoneal dialysis in many parts of the world, including the United States, is this incessant focus on mortality. And, and because there's been the incessant focus on mortality, in what I'm going to present to you is going to be a lot in mortality because that's what's been published. But I think this is important to keep a perspective on what is meaningful to patients is often not the same as what is meaningful to health professionals. And health professionals is not just physicians, it includes nurses, dietitians, other members of the healthcare team that was surveyed as a part of that, in how dissociated our thinking is in what's important for research for people with kidney disease compared to what patients and caregivers value. So what of the outcomes that have been studied? As I've said, I think the most work has been done on death, and I will present the data on death just to make a point. The time on PD, which is the technique survival or technique failure, I'll spend some time on that, and a little bit on peritonitis. So let's start with death. And I think I just want to start off by, this is a study from Canada by Stan Fenton in Ontario, but this is using the data from Canada as a whole. It is this important study, along with several others that came around that same time, that have resulted in PD being viewed by many nephrologists as an inferior therapy. And what these studies showed here at this time is that if you compare people that start treatment with hemodialysis, this is hemodialysis right here, and this is peritoneal dialysis. So it seems like early on, there are fewer people treated with PD that are dying. So there are more people on hemodialysis that are dying. But after a point in time, that reverses, so that there are more people with PD dying off. And people have made this into a science. This observational studies become a science, that these differences that we are seeing are because of what hemodialysis does or what peritoneal dialysis does. It is not which the patients that are treated with different therapies, but has been concluded to be the direct effect of being treated with PD. That if these patients were doing hemodialysis, they would have lived a little bit longer than which is of course not true. I mean, I think it is wrong to look at a study like this and come to that conclusion. But I think studies like this have singularly hampered in how PD has been viewed in many parts of the world, including the United States, that has made it what I call as a niche therapy. It is done by some patients, treated by some physicians, but it's not for everyone, and not every physician takes care of patients in PD, which I think is a huge problem. So the conventional narrative is that this relative risk for death change over time so that PD is good early in ESRD, but is a significantly inferior long-term therapy. So you can start some people with PD, but at a certain point, you better switch them to hemo if you want to care about your patients. The corollary has also become that PD can be successfully done only in the presence of residual kidney function, which is an enduring myth which I could present data for 30 minutes to people, to smart people, and in the end they would say, oh, but by the time the residual kidney function does, it's really difficult. But they themselves have never taken care of a patient in PD. That's all right. And so most of what ails long-term PD is this high glucose in bioincompatible solutions. That has been the other enduring myth in my mind, that it causes damage to the peritoneum, which I think is true, but I think the systemic effects of glucose are overstated. I strongly believe that. Now, what I want to, I think I view Canada as a different part of the world in which PD is viewed more favorably than in the United States, and so maybe I'm preaching to a group that doesn't need to be preached to. But this is a study that we did some years ago, which was quite a surprising finding. We looked at, this is the time between 1996 through 2003, when the proportional use of PD in the United States was really going down. Fewer and fewer people were doing PD, and the question that I wanted to see is what is happening, how well are people doing in that time? What was surprising at that time to us, which has now subsequently been shown from around the world, is that in this period, there has been little or no change in how well or how poorly people on hemodialysis do. It's really people that started hemodialysis in 2002, 2003 did as well or as poorly as people in 96, 97. In contrast, people that were starting treatment with PD over time had a progressive reduction in the risk for death. So the probability of a person starting PD dying went down over this period quite significantly. This is looking at 1 year. This is a 17% better outcome for people that started in 2002-3 compared to 96, 97. As a result of this, I showed you an iteration from Canada in which at the end of 5 years, fewer people treated with PD were alive compared to people starting hemodialysis. This is the data from the mid-1990s. As you can see, over time, this red curve has been pushed up. So that at 5 years, there was absolutely no difference in the proportion of people treated with hemodialysis dying compared to those treated with PD. These were superimposable curve. Now, my hope is that with this, we're going to put this issue of death to rest, that this is not a problem with PD. And if you look at 10-year survival, also there is absolutely no difference. And you could argue that PD does as well or as poorly as hemodialysis. 10 years out, only 12% of people are alive. 88% of people that start dialysis 10 years out are dead. So you could say equally good or equally bad. And greater improvements with PD have also been seen every place in the world that has chosen to look at this. I want to start with Canada because that's where I'm right now, and as you can see, this is the kind of the curve that Stan Fenton had published early on, showing again that there was a higher risk for death at 5 years with PD than with hemodialysis. If you look at the 2001, 2004 era, these are effectively superimposable curves, similar to what we see in the United States. So there is a similar risk for death at 5 years in people treated with PD or hemodialysis in Canada as in the United States. And you can just go on and on. I have 5 or 6 additional slides from 5 or 6 additional parts of the world to make that same point. As you can see, this is Europe. This is showing again that in Europe, early on, there was this higher risk for death for patients treated with PD after 2.5 years of treatment with PD. This is, just to orient you, this is 1993 to 1997. 1998 to 2002, it was still higher long-term risk with PD, but in the most recent cohort, PD does well all along for 5 years out. So North America, the same results. Europe, the same results. These are the results in Denmark. I don't want to belabor the point, but the point is that similarly, there have been greater improvements in this country of Denmark for patients on PD than for patients in hemodialysis. The same thing with Taiwan. In Taiwan, they showed initially in these early periods poorer outcomes with PD, which are the same now as they were before with hemodialysis. The same point from South Korea, the same point from Australia and New Zealand. The theme is very consistent. It's actually quite amazing that something that we just stumbled upon has been replicated from every part of the world that has chosen to look at it. So if I can summarize then, what are the trends in mortality outcomes with PD? I would say that there's a remarkable similarity in results of studies from 4 different continents. There has been a greater improvement in the risk for death for patients treated with PD than with hemodialysis. And there is no evidence in my mind that treatment with PD compromises long-term survival of patients. Why has there been a differential change? Why have there been more improvements in patients in PD than in hemodialysis? I don't know. Unfortunately, I cannot point to any study that has looked at this. People have argued patient selection, and I've put a please with an exclamation mark, because I think patient selection is very pejorative. It's very paternalistic, that I, as a physician or a healthcare team, will select who has the opportunity to be treated with PD. I don't think it's in my place to do that. It's for the patient to decide. And any patient who wants to do PD should be able to do PD. And so I take offense at the notion that this is patient selection. I do think a lot of that could be to do with individualized prescription management. That builds on what Tom talked about in terms of kinetics and how you can apply PD and its flexibility to a lot of patients. There has been greater investment in quality improvement. There clearly have been reduction in risk for peritonitis that in itself could be one of the explanations, and I will spend a little bit more time talking about peritonitis, but more importantly, how the benefits in reduction in peritonitis are unequal. There are centers that have done extremely well, and there are centers that are still struggling. And I think that is important for the PD community to take notice and act upon. What about transfer to hemodialysis? So this is an observation that I want to make about that. It is always going to be that patients on PD will be more likely to be transferred to hemodialysis than the opposite. It's always going to be. And the reason, for one, there's only one peritoneal cavity, and there are 6 or 8 potential or more vascular access sites in any given individual, so that if one peritoneal cavity fails, there is no second peritoneal cavity to replace. But there is one vascular access site fails, you can move up and on the opposite side into the groin, in the back, where you want. You have multiple options there. The second thing is, of course, PD is a self-care therapy. If there is a change in a patient's health that precludes self-care, or if they have family support, let's say there's an elderly couple and the wife is helping the husband and the wife has healthcare problems, that she's no longer able to provide care for the husband, necessarily that patient would need to transfer in center because of loss of support and or independence because of their change in health, which would not be the case for hemodialysis. So I think we have to accept the notion that patients in PD will be more likely to transfer to in-center hemodialysis than the other way around. It's inevitable. But a higher transfer rate is not inevitable. As higher transfer rate has been, in the United States, on average, if you look across the dialysis providers, DaVita, Fresenius, about 20% of patients in PD transfer in-center every year, 1 out of every 5. And I think we can do a lot better than we have done. Which patient gets transferred often depends on who is treating the patient, where and when. So I, as a physician, may choose to maintain a patient in PD, while another physician may recommend the patient to switch to hemo, and people have different thresholds in doing that. This is just looking at what has happened in the United States about the same time when the risk for death was going down. people were being retained on PD for a longer period of time. And so that people that started PD in 2002 to 2004 were less likely to transfer to hemodialysis than 96 to 98. Some of that, so what the reason for that is, again, we don't quite know, but this was reassuring for us to see that there's a parallel trend in people being maintained in PD for a longer period of time. The data from Canada actually is much less consistent. Canada, the improvements in Canada have not been sustained. So this is just actually, this illustrates this better. This is, on average, the time to transfer to hemodialysis, 95 to 2000 was 1.9 years. There seemed to have been an improvement in this intervening year that seems to have slipped back. So this is the mortality curve. This is right here. This dotted line is the mortality curve that has gone down for Canadian PD patients around this is consistent around the world. This is the transfer to hemodialysis that was decreasing but has bounced back up. So I think one has to be very mindful of what we can do differently to be able to maintain patients on PD longer so that we can have sustained improvements in maintaining people on PD longer, because I think it is not inevitable that the transfer rate be this high, and we can do better. So we can influence, this is the program I used to run before I moved up to Seattle. This is in Los Angeles. And this is the percent of patients transferring to hemodialysis. As you can see, this 2012 is when I moved. This is through 2011. In this 3-year period, having a sustained focus on maintaining people on PD, we were able to reduce the proportion of people transferring by almost 50%. As you can see, as I said, in the United States, 20% of patients transfer from PD to hemodialysis every year. And in our unit, we had less than half of that proportion transferring. So yes, in part, we're very proud of what we did, but the point of it is that we should not accept it as inevitable that a high transfer rate will happen. We need to identify for our center what the reasons for transfer of patients from PD to hemo are, and identify opportunities for improving what we do to retain patients for longer. It is a continuous learning exercise that needs to be happening at the level of an individual facility and not necessarily at the level of a province or a nation. And there's one of the things that has consistently been associated with how long people stay on PD is how big your program is. So bigger your program, fewer the proportion of patients that transfer. Again, this has been shown from around the world. Excuse me. These are data from the United States, but there are same studies from other centers in the United States, from Netherlands, from Canada. So I think one of the most important things, it is not necessarily that the medical care in a large center is better. I shouldn't say medical care, I should say the expertise and the skill set of individuals is not necessarily better. It is the system problems that preclude us from maintaining patients in PD. Those larger programs are more likely to have solved them than the smaller programs. And the bigger programs probably are able to provide the support to patients much more consistently than the smaller programs. But I think it is very important in that. At least in the United States, and I know similar data exist in Canada, one of the groups of people that we don't do as well in being able to support on PD are the racial ethnic minorities. And this is just looking at, this is from a United States perspective, looking at blacks, Hispanics, Asians, and others, looking at the risk for transfer to hemodialysis. What is consistent that the blacks have a much higher rate of transfer from PD to hemodialysis than the whites. Asians, in contrast, have a lower risk for transfer. So one of the lessons I take from a study like this is that the programs in the United States need to do a better job in being able to relate to and support people that are African American like they do for the whites. And it takes not the medical, but the psychosocial, emotional skill set to be able to support a diverse, racially ethnically diverse patient population, so that the skill set and tools that you need to support people from different groups is different. And the program needs to be sensitized to that. They're the First Nation people in Canada. There are similar data from the First Nation people in Canada that they have a much higher rate of transfer of PD than the white population. And I think the programs need to think of those groups differently in identifying approaches, different approaches that work for different groups of people, rather than using a one-size-fits-all in managing a PD program. And I think that's a big take-home message for me as I think about this. And I also think that technique failure, that is used, a very pejorative word, I think, is often not a problem with PD, but as a result of how PD is practiced. I think each program has to look inwards and not outwards or blame the therapy, but see what are we doing that we need to do differently to support people on PD longer, that others are doing better than we are. This means the dialysis providers and physicians have the ability to influence and substantially reduce transfers of PD to hemodialysis. And I think this is something that is important for every program to embrace. So I think one of the most important things that I think in big 30,000 feet view is I think every program needs to be positioned both for growth and success. I think every larger programs have better infrastructure to support patients on PD longer. And I think to maximize patients selecting PD as a dialysis modality, and I think regional centers of excellence is an important way of doing that. And each program needs to have a culture of continuous quality improvement, in which you plan what you want to do it then, but then check what the results of what you implemented were, and then be ready to recalibrate should you need to recalibrate. This is the plan, do, check, act model of quality improvement, which I think needs to work for all of us. So I'll get also then to reducing the risk for infectious complications. The catheter patency is an important issue. There is the issue of volume management, and then in how we handle mechanical complications. These are some of the reasons that explain why, in how different programs manage these 5 things, often explains why different programs have different rates of retention of patients on PD. So that, for example, if you have good support from a surgeon, or if you have a nephrologist that is putting in catheters, for example, they would have a better overall retention in PD compared to those that have a spotty support. And I think those things need to be sorted out for you to be able to maintain patients on PD longer. What about backup fistula in PD patients? This is invariably, in many of the talks I give, there's at least somebody who comes and asks me that. I don't know how commonly viewed this is or how commonly this is practiced. I just give this as an example. This is an old study. This is a study from the United Kingdom, but I still think it's instructive even today. So they had, in this period, this is, of course, early days of PD, 176 patients starting PD. Of these 176 patients, 114 of them had 153 fistula placed. So most of them had a fistula placed. Many of them needed a second procedure to be able to maintain a fistula. We know fistulas are no panacea. Over the follow-up period of these 114, of these 176 patients, 33 of them needed an emergent hemodialysis, which is often peritonitis or something else happened. They needed emergent hemodialysis. Of those 33 people, only 10 of them had a functional fistula. 23 of them, the fistula was not working when they needed it. So 30% of the time the fistula was working, 70% of the time it was not working. 81 patients, 71% of them did not need any emergent hemodialysis. So the point of it is that 39 patients needed 2 procedures. 94% of the fistula were never used. 70% were non-functional when needed. So I think it's a tremendous resource wastage with no tangible benefit. It needs to be, there's an occasional patient that you may be concerned about in your ability to maintain them on PD. That patient, to approach them to get a fistula in place seems like a reasonable choice, but for that to be a policy for all patients is a mistake. So, and I also think that it detracts from the mission, focus, and goal of the PD program, which is to maximize transplantation rates and minimize transfers to hemodialysis. So maintain people on that modality for as long as you can. The backup fistula is a tremendous waste of resources, and I think the health-related risks in the heart, for example, exceed the benefits. And it's the wrong message to referring physicians, PD nurses, and the patients. Essentially, you're saying that PD works for some patients some of the time. What the patient is presently doing is not going to work. And I think it takes the eye off the mission, focus, and goal of the PD program to be focused on preparing them for what seems to be a sense of an inevitable transfer to hemodialysis. When I finish in talking about peritonitis, I think there's no doubt in my mind that in the 3 decades that we've done PD, overall there's been a substantial reduction in the risk of peritonitis. And the things that I think, 4 things I've listed that I think have worked and are prime contributors to this reduction. First is just the connectology, the flush before fill, the disconnect system, the lower locks. This, I think, is the singular most important and influential reason why peritonitis rates have gone up, is because of improved connectology. We also, the application of exit site antibiotics. There is improved training of patients and staff, and then fungal prophylaxis with antibiotics. These are the 4 most important things that have reduced the risk for peritonitis. Yet it's still the single most common reason for transfer of patients from PD to hemodialysis. And what I find most concerning is a substantial center-to-center variability. And it is quite amazing in how much variability there is. This is the UK Thames area. This is to orient you, this white bar and this shaded bar are 2 different years. So what is clearly evident is that there is the average number of months between peritonitis. So if there is a lower interval between episodes of peritonitis, it is a high peritonitis rate. It's actually bad. So this, for example, is the worst in this particular year, the worst performing center. And these 2 centers are the worst performing centers. And these are the best performing centers. There's a 3-fold variability in peritonitis rates on average between these centers in the UK. 3-fold. We're not talking about a little bit of a difference. It's a 3-time difference. It's huge. It's Donald Trump, sorry. This is Australia. Australia has about 60 or so centers that do PD around, and Australia, I think, has been the leader in terms of publishing on peritonitis at a national level. And this is the incidence rate ratio. So here, a lower number is a better peritonitis rate, the opposite of that. But just without focusing on what each one of these, the triangles versus the circles mean, but here you have this center is 0.4, this center is about 1.5. So this is about, a 3-fold variability, again, between centers in Australia. And what they've done is they've tracked in Australia year after year. The good centers are good centers year after year. The bad centers are bad centers year after year. And so clearly, it is the difference between centers that is, I think, in my mind, one of the biggest action items for the PD community. We need to reduce this variability all towards a very low rate of peritonitis. And the centers that have the highest peritonitis rates, the burden lies on them to get it down. So why is there such variability? In any time that I've talked to people about things like this, it's the patients, right? My patients are just poor or sick or older. They don't listen to what I tell them. Your patients are better than my patients. They've looked at this. They in the recent analysis from the Australia and New Zealand data, there is some contribution of patients to this. But it's a very small, only 15% of the variability from one center to the other is explained by patients. And in fact, this issue of my patients are the problem is a wrong answer for any quality improvement metric in which it's been looked at. People have looked at, for example, in mortality after cardiac surgery, or length of stay after pneumonia, or readmission after pneumonia. You name a disease state in which people have looked at the contribution of patients as the explanation for why two programs are different, and every time it's not the patients. It's what the program does. The most important is what the center does. And if you take into account the differences between what the center does, that's about a third of the difference between the centers. And of course, what the center does, some of them are intangible. So for example, the skills of the nurses in teaching patients is not something that you can quantify. And so that, of course, is not considered when you're talking about center practices. I thought I'd adjusted this setting, but it just lists the differences that they looked at. The patient census, the percent of dialysis patients treated with PD, antifungal prophylaxis, application of antibiotics at the exit site, and on and on. It is amazing to me that about half, despite 5 or 6 clinical trials that have shown that daily application of antibiotic cream at the exit site reduces risk for peritonitis, about half the programs in the United States don't use that. It's absolutely stunning to me. And this is not just the United States. I've spoken in places around the world, and they say, oh, no, we don't get peritonitis. We don't use it. We just don't do that. But it's that don't do that. But that is what explains the centers with a high peritonitis rate compared to the low peritonitis rates are the centers that refuse to implement interventions that have been demonstrated to be effective. That explains the variability. All right. This is my last slide. So this is what I've tried to say in the last 35 minutes or so. I think we don't study or consider the outcomes patients and caregivers care about. And I think we're becoming more sensitive to that. And I think hopefully the next decade or so will make that transition away from this incessant focus on mortality. I did focus on mortality and demonstrated that there have been greater improvements with PD around the world, and the long-term outcomes with PD now, with regards to risk for death, are the same as with hemodialysis. The third point I tried to make is that technique failure is not inevitable. It is modifiable by center practices. And finally, in my mind, there is an unacceptable center-to-center variability in peritonitis rates, which is largely attributable to disparate application of proven methods to reduce peritonitis. I'll stop there now, and the time for comments or questions.
Hemodialysis modality more than into PD modality. Do physicians get remuneration differently in various modalities? What do you think?
There's absolutely no question in my mind that whether it is public policy, particularly as it pertains to reimbursement, is an extraordinarily important driving influence on the relative use of any given modality. In the United States, historically, Medicare has said that they incentivize PD. I can speak better to the United States than any other part of the world because that's where I come from. Having said that, that was true only in part because the reimbursement for the technique of dialysis was the same, but then they would pay per use for injectable drugs like EPA. And it is what I showed you, what the transformation happened with regards to use of PD was because they said rather than EPO being a source of income for you, it's now an expense. And so if you use less EPO as for patients on PD, then you can keep more money for yourself. And so they added more money to patients for PD, which I think is the singular most important reason for the focus on growing PD in the United States. Physician reimbursement is a bit more, it's a bit more challenging. There are two parts in the world in which physician reimbursement was changed, so some kind of an ecological test, if you were, in which the potential disincentives to physicians were taken away in Ontario, Canada, and in Germany. And at least over time, there was no change in use of PD. But I think it is a very strong incentive that drives that. There are very nice studies that have been done in Europe, in which they've divided up countries in which there is a predominantly public funding of healthcare versus private funding of healthcare. And it's day and night with regards to PD use. Where there's public funding, where there's an incentive to control costs, there is much greater use of PD. As against countries like Germany, for example, where there's a private funding system, there is little or no incentive to control costs. There is much lower use of PD. So I absolutely strongly believe in the premise that you raised as being a very strong determinant of proportional PD use around the world.
Dr. Dasgupta had mentioned to me, and perhaps, Myrna, if you want to, I can make the comment that he made to me, because when you showed Jeff Pearl's data on the technique failure in Canada, one of the things he said to me first up was, wait a minute, those patients were being transferred to home nocturnal. And that, well, you'll have to respond to that. We'll see Jeff and ask him that. But that's what Dr. Dasgupta suggested might be part of that explanation. It does make sense, because that's a very attractive alternative therapy. My comment is so a little bit of an offshoot of the question that was just asked. Your view of patient selection and mine are 180 degrees opposite. I think of patient selection as patients selecting the therapy. You used it as caregivers selecting patients. And
Healthcare providers, not caregivers.
Okay,
That's
correct.
different.
You're
Yeah.
correct.
Yeah.
The healthcare providers, the physicians, the nurses, making that decision. And in my experience, I think there is a patient selection bias. I think patients that choose to go home are more motivated. Mm-hmm. Certainly in our program, they have much better health insurance. Their duration of care prior to going on dialysis is longer. They've seen a nephrologist more. So I do think there is patient selection. So I'm using the same term in a different way than you do.
No, I mean, no disagreement there. I mean, I think this is a decision for the patients and caregivers to make, and not for the healthcare team to make. I strongly feel the role of the healthcare team is to support the patient in whichever decision they make, and try our utmost for them to succeed in the decision that is best aligned with what they want out of life on dialysis.